Assalamu alaikum, dear Diploma Examinee. Welcome to episode number 4 of Rashtra Success. So today we are going to talk about another clinical topic that is very much excellent and important for your exam. So I will start with a clinical scenario, as clinical questions are commonly found in SBA segment as SBAs. So to learn about a clinical scenario, to learn about the clinical picture, and to learn about the pathognomic sign that will guide you to the diagnosis is very, very important for us. So it goes like this. A 25 years old male patient came to you with the complaints of fever, shortness of breath, and chest pain on the right side. On examination, you have found the features of right-sided pleural effusion. On query, patient gives history of fever for last 3 months, which is associated with evening rise of temperature and night sweats. And shortness of breath is recently developed with chest pain. What is your clinical diagnosis? So this is commonly a case of right-sided tuberculous pleural effusion. As we all know, tuberculosis is a chronic disease, and here the history is usually a long time, like fever for last 3 months, and recently he developed shortness of breath due to pleural effusion, and also chest pain due to pleuritic chest pain, which is also associated with tuberculous pleural effusion. So tuberculosis is one of the commonest scenario you can find in your diploma clinical segment. In tuberculosis, we have to focus on fever. Fever is usually low grade with evening rise of temperature and night sweats. So let's talk about what are the other differentials and how you can differentiate it from that. So another very important differential is parapneumonic effusion. But in parapneumonic effusion, you will find the history to be short, like fever for last 15 days, and recently he developed chest pain. Okay. Another important differential is lymphoma. So in lymphoma, there may be also fever, but for fever, the history will be different. Here, fever's history can be long, but fever will be periodic fever, which is also known as pale abstent fever. Pale abstent fever means patient will feel fever for 7 days, and there will be an afebrile period for 3 to 4 days. Again, he will have another episodes of fever attack, and it will be associated with drenching night sweats. Patient will tell, usually when I am sweating, I have to change my clothes. This is drenching night sweats. And in both cases, you will find the history of weight loss. But in parapneumonic effusion, there will be no associated weight loss. This is very important. Okay. And in tuberculous pleural effusion, first the symptoms are, we have already talked about it, fever, cough, hemoptysis, shortness of breath, chest pain. Signs. In signs, you will usually find the examination shows evidence of pleural effusion on right side, right? In TB, clubbing is very uncommon, and in lymphoma also. Okay, so how can we differentiate from lymphoma? In lymphoma, it is expected to have a palpable lymph node which is rubbery in consistency. That's an important differentiating point. It can be also found in tuberculosis, but in TB, it is matted and firm in consistency. Okay, so let's talk about the investigation. First, you go with some baseline investigation like CBC with ESR. The expected findings are, in CBC you can find leukocytosis with increased lymphocyte count. Any chronic inflammation, there is raised lymphocyte count. Another is 3-figure ESR. So ESR can be raised. 3-figure means 100 and more. Next, we can do SGPT, serum creatinine, RBS to exclude diabetes, and ECG, and chest X-ray. First, chest X-ray will guide us if this is effusion or anything else. After getting effusion, you do ultrasound, chest ultrasound, which is also known as point of care ultrasonography of chest, POCUS. In POCUS, you will do USG guided pleural fluid aspiration. After fluid aspiration, first the appearance is amber or straw in color that goes in favor of tuberculosis, and next you will do some biochemical test that will show exudative pleural effusion. Then you will do ADA, which will be raised more than 40. Then you will do LDH, that is usually raised and more raised in lymphoma. Most important you have to do is pleural fluid gene expert. The sensitivity is about more than 60%. Okay. Another important is you can do pleural biopsy. This is very significant because pleural biopsy has a very high sensitivity for tuberculosis, as tuberculosis involves the pleura diffusely. Okay. So you go with this investigation. After the diagnosis is completed, you start anti-TB medication. Anti-TB medication, we all know, category 1 should be started with the initiation phase of 2 months for FDC and continuation phase of say 4 months to FDC. And you have to follow up the patient and also give this patient some non-pharmacological management, like you can give him 3-ball incentive spirometry that will reduce the fluid quickly, and also there will be less chance of pleural thickening. Okay, so this is a 25 years old patient and you are aiming for tuberculous pleural effusion. But if the patient was 65 years smoker male patient, you must exclude malignant pleural effusion and go for malignant cell in pleural fluid and also pleural biopsy histopathology. Okay, so what will be the biopsy show? The biopsy usually shows granulomatous inflammation with caseating necrosis. Always remember, caseating necrosis means active tuberculosis. Okay, so that's all from today. Hope you learned something new today, and please do like, comment and share our video, and we are rushing towards our success. Assalamu alaikum.